you, and thank you for that lovely introduction. So I wanted to dive in immediately with what I perceive as psychiatry's greatest challenge, which is the level of explanation at which we should understand and also, in fact, treat mental illness. And the problem is that the level of explanation we have access to is the one on the right, people's subjective experience of symptoms, and we sort of find ways of categorizing that. The level of explanation that I suppose we would like, we meaning brain sciences more broadly, would be some kind of very specific molecular dysfunction that we could target, modify a drug to target, and then, bingo, we would be there. And I probably believed that would be the case at the very beginning of my career, like just when I was coming out of my undergraduate degree and I wanted to study neuroscience in this field. And I thought, if we could capture underlying neurobiology, we could treat it, much like has happened historically with something like epilepsy, formerly a psychiatric disorder, now something where we have a pretty decent understanding of the underlying neurobiology and then how we can treat that. Unfortunately, I actually think that is unlikely to be the case with at least many psychiatric disorders, because I think the level of explanation that is most useful for mapping between someone's experience and the types of treatments that we have, including psychological, pharmacological, and other types of treatments, is actually the level of cognition. And you can capture this in a lot of different ways, but I think this is the level at which many treatments work as we understand them, and also the level at which perhaps is a kind of satisfying level of explanation, or at least I would say a useful level of explanation for the types of symptoms that someone might describe subjectively. And so I'll try to kind of convince you of that viewpoint, I suppose. Not everyone shares it. I'll start where I started, which was where I thought you could identify a particular neural dysfunction in a disorder like major depression and then treat it. And I did this during my PhD. I focused on an area of the brain called the dorsolateral prefrontal cortex. And I ran a bunch of studies, some of which showed that there is dysfunctional activation in the dorsolateral prefrontal cortex, specifically hypoactivation, underactivation, when you're doing a very difficult task, like an executive function task. And this is different from people without depression and even people with relatives who are depressed, so who have a genetic risk of depression. It's significant at the group level. You can see there's a lot of variability if you look at those pink dots and how they spread. Nevertheless, I had the belief that you could identify this sort of dysfunction at the group level and then target it with a number of different treatments. Some treatments affect this particular type of dysfunction, some don't. So I'm showing you actually some later work, but it kind of recapitulates this idea. So at the top, you can see that across lots of different pharmacological therapies, this is like common antidepressants, slightly less typical antidepressants, you see changes in one region of the brain, a very distinct one, subcortical, called the amygdala, whereas you see more prefrontal regions, not actually dorsolateral, but more prefrontal regions that change after various kinds of psychotherapy. So you might say, okay, we're perhaps getting in this sort of region of change with psychotherapy, but we're not targeting that region directly, and we're certainly not with drugs. So maybe there are other ways that we can change activity in this region, and indeed those types of interventions have been developed, were developed before I started doing this, like transcranial magnetic stimulation, a way of changing activity relatively precisely in this region, or transcranial electrical current stimulation, a way of changing activity not so precisely in this region. But I used the latter because of feasibility. So I ran a study which was a clinical trial in patients who were in a severe depressive episode. They were all unmedicated and they all wanted psychological therapy. Half of them had TDCS enhanced, brain stimulation enhanced psychological therapy, upregulating activity in that region that I'd identified, and then 8 weeks of psychological therapy and measuring clinical outcomes as well as brain stimulation outcomes before and after, compared to a very well-matched placebo group. But what I found, and indeed what many, many, many trials in depression and other psychiatric disorders have found, was a variable response. In my case, even I could predict using the brain scans that there were some people whose dorsolateral prefrontal cortices looked a certain way who responded to this intervention and others who didn't. And it's not always this brain region and this intervention, but the story is very similar. That when you give a particular intervention, whether that's a new type of drug, whether that's an anti-inflammatory that's come out of Cambridge a few years ago, whether that's a type of psychological therapy, you see this real heterogeneity of response. Sometimes you can predict it, sometimes you can't. And really, you don't even have to run a trial for that. You could just ask patients. If you look at the DSM, there are a myriad of ways that you can be diagnosed with the same disorder. You can even have two people, same diagnosis, no overlapping symptoms. So it's this position from which computational psychiatry starts. The idea that we need a way of formalizing mental illness in order to treat it at a mechanistic level and perhaps segment people into groups that would be more likely to be treated. So it's moving away from the idea that you have like a diagnosis and that maps necessarily onto a treatment, onto some kind, and these are broad brush words because you can do it in lots of different ways, some kind of mathematical formalization of behavior or brain, sometimes other things, in an environment, which is a very important context of much of computational psychiatry, and then you use that to phenotype a particular participant and ideally map that phenotyping onto a mechanism you know a treatment changes. So in some ideal world, it would be you have these different kind of computational phenotypes, and those align with the intervention or interventions that you're interested in. As I see it, there are two main goals. The first is that segregation for treatment selection. You take the treatments you know about, you map people onto them. So rather than what happens at the moment, which is more or less a random decision of what drug to give someone, often based on side effects, so that's sensible, but not based on likelihood of treatment response, to something where we would be able to assess someone, often using a series of measures, and then say, you have the type of profile that responds to a selective noradrenaline reuptake inhibitor because you have a very anxious depressive phenotype, for example, that shows uncertainty behavior on this task, XYZ. So that would be the kind of level you'd be looking at. I'm also interested in a second goal of computational psychiatry that emerged a little later and which I and some other colleagues were sort of championing, which was the idea that we could use these methods to actually innovate the treatments themselves. And so hopefully I'll touch on that a little later, but the idea is that these mechanisms might not just tell us how to shuffle people into different groups, but actually tell us how to improve the treatments. And finally, the thing I wanted to address before getting into the nitty-gritty of how we do this is why bother in the first place? So you might say, wait a second, you didn't need those trials. You just said you could do this at the level of the symptom. You could understand this problem at the level of the symptom. So why can't you do this kind of classification at the level of the symptom? And lots of people have wondered that too. In fact, they've tried. And there were some really kind of high-impact findings in this area. This is great work by Adam Chakru, nearly 10 years ago now, showing that you could cluster people based on symptoms and similarly come up with a different sort of computational phenotype. This, by the way, counts as computational psychiatry. It's just a slightly different branch of it that I'm not going to focus as much on today, except for this. So he showed that there are these sort of different subgroups based on symptoms, and they showed differential responses to different types of antidepressants. It was really formative work. Unfortunately, it turns out to be very, very difficult to generalize to other samples where these particular machine learning models were not trained on. It turns out that even in really large data sets, trying lots of different things, actually in this paper even trying inflammatory markers, so not even just symptoms, they failed to generalize. So I would actually say that there are some serious limitations to just looking at the symptom level, and maybe that's because that isn't actually the appropriate level of explanation, or maybe a deep enough level of explanation for mapping on with the sorts of interventions that we have. A symptom maybe could come from many different mechanisms. Here's what I'll talk about today. We've just talked about why do we need computational psychiatry. I'll start with basics of computational psychiatry. How does it work, and how do we apply it to a mental health symptom? I'll tell you about one study, and I'll tell you a tiny bit of the kind of maths behind it and how we do it. And then I'll tell you about one of the broader goals of my lab, which is to apply this to mechanisms in the body, and why I think this is so important and so exciting. And then finally, at the very end, I'll talk about applying this to treatment, which is something I think is incredibly important to bear in mind, even in the other parts, because that's sort of the end goal of every segment. So the first type of computational psychiatry I want to tell you about is computational psychiatry of motivational symptoms. This is one of the core symptoms of major depression, anhedonia. So there are two core symptoms of major depression, low mood and anhedonia. You don't actually need low mood to get a depression diagnosis. You could just have prolonged anhedonia, which is a lack of pleasure or motivation for normally pleasurable activities. But what does that actually mean? Where does this come from? So the idea of computational psychiatry is to look neurally, cognitively at what the proximal cause of anhedonia is. What are the mechanisms that are leading to this experience of a loss of motivation, a loss of desire to seek out normally pleasurable things? And to that, we look at various aspects of cognition and then try to understand them with mathematical models. So the aspect of cognition that is perhaps most related to anhedonia, and the one I'm going to focus on here, is effort-based decision-making. This is a large literature on how we make decisions to weigh up reward and effort, and you can see quite naturally how it relates to anhedonia kind of conceptually. But the way that we decided to measure this was in a very large sample, population matched for diagnosis. So a large subset had a diagnosis of major depression, but the data I'm going to show you is dimensional, although we replicated it in the subgroup with the diagnosis. On this task, which was developed by my brilliant postdoc, Sarah Merhoff, participants have a choice to expend effort, which is like lots of very, very quick button clicks, but I've done it. It is actually genuinely quite physically effortful for a certain number of rewards. And we've gamified it so that you're like a little octopus trying to catch a shrimp, and then you get to know the sort of number of rewards for the amount of effort you have to put in. The number of rewards are like the number of shrimp. You have to click fast enough to get the reward. And we do various clever things in order to carefully calibrate what your sort of trade-off between reward and effort is. First, the effort itself is personalized. It's calibrated. Obviously, not everyone has the same sort of physical ability to click, so that's irrelevant to the task. We calibrate it for you personally. And then we also present trials in this sort of clever staircasing way. So we make sure to initially figure out, what are your tricky decisions? What's your kind of tipping point between how many shrimp you'd want for those amounts of clicks? And then we give you trials around that tipping point in order to kind of figure out exactly what your variables of interest are there. And then from all those, we can then fit a mathematical model. In fact, we actually fit many mathematical models. I'm going to show you today the winning model, but we use various processes to compare these models and figure out whether each component is important in terms of people's decision making. So we can kind of simulate behavior and see how closely that matches to real behavior, and do other techniques to make sure that this is sort of the right model or the best model we can come up with at the time. So the idea in this model is that in your decision about effort and reward, you have a particular subjective value of that trial, and then that value goes into whether or not you are likely to accept that reward for that effort or that decision to make. And so we then fit various, they're called free parameters, and I'll show you how they work in a second. One is on effort sensitivity, so how sensitive are you to that difference in button clicks in effort levels? How sensitive are you to the differences in the number of shrimp, in the number of rewards? And then finally, how likely are you, irrespective of your effort and reward sensitivity, to actually accept effortful decision in the first place? And here's a little bit how it works mathematically, just to give you a sense of it. So let's imagine you have a high effort sensitivity. What that means is that you are likely to calibrate your subjective value quite steeply. So based on how effortful something is, you're likely for something to have a high subjective value if it's not very effortful, and a low subjective value if it is very effortful. You've got a steep curve. In contrast, people with a low effort sensitivity, it's a flatter line there. It doesn't really matter to them how effortful it is. The reward sensitivity works similarly. So someone with high reward sensitivity means something really has a lower subjective value if it's not very rewarding, and a high subjective value if it is very rewarding. So that influences your subjective value quite a lot. It doesn't much in people with a lower reward sensitivity. But both of these then go into your probability of actually saying yes. And the variable that finally tweaks that probability of saying yes is this parameter acceptance bias. And the way you can think of acceptance bias is if you have a very high acceptance bias, you kind of say yes no matter what. You're always willing to take the challenge. If you have a very low acceptance bias, actually you need a very high subjective value. So something needs to be really high reward, low effort, etc., for you to actually say yes to it. And what we found was that this acceptance bias, so that parameter and that parameter only, loaded very strongly onto people's anhedonia and also a neurological symptom that's very close to anhedonia called apathy. I can show you this dimensionally, it's a little more intuitive. The higher someone's anhedonia was, the lower their acceptance bias was. That is, the lower their likelihood of accepting a reward for a given effort in general. So this is quite an important finding because it means it's not about how sensitive you are to effort or in fact how sensitive you are to reward, which is what you might have predicted going into this. It's actually like the intercept. It's actually like generally how likely you are to agree to expend effort for reward. And this is quite a distinct parameter. It's also one that many people haven't included in their models, and so they end up getting quite different conclusions. But we tested it against other computational models. This is sort of the power of computational psychiatry to show that adding this actually really did fit the data better. But I've left off, of course, my biggest area of interest, which is you're taking all these variables from the world around you, you're taking rewards, you're taking efforts, you're making your decisions, but at any given time, you are faced with a huge amount of information. Your brain is faced with a huge amount of information coming from your body. This is just a feature of being alive. And those things, too, influence various aspects of your cognition and aspects of your mental and physical health. Again, you see this just symptomatically. So physical symptoms are incredibly common across mental health disorders. When you speak with people with lived experience, they tell you about a huge diversity of physical symptoms, some actually that we didn't even know about. So for example, many people report bladder symptoms, many people report muscle tension symptoms, things that actually are very rare to investigate in this area. But the real take home when you speak with someone with lived experience, and this is a bunch of different psychiatric disorders, is the diversity of bodily signals that seem to be different across psychiatric disorders. The kind of neuroscience version of this is that if you look across many different psychiatric disorders, this is on the right, across depression, anxiety, bipolar disorder, psychosis, you see a common difference in processing in the brain during interoception, processing signals from the body, in the insula. So there's not only this kind of patient experience of physical symptoms, but there's this maybe common neural basis of these distinct experiences of bodily symptoms. And all that is to say that this is a really important, albeit quite neglected area to investigate from a computational perspective, from a cognitive perspective. And if I haven't convinced you yet, then I'll tell you the kind of final, maybe most convincing aspect, which is that mental illnesses like depression have a really, really sad mortality gap. And closing that gap is vital. But the thing that causes that gap more than any other variable is actually not accidents or suicides in the case of depression, it's cardiometabolic disease. So we need to decrease that mortality gap by addressing physical health in mental health conditions. I've used the example of diabetes here. You can also use other kinds of examples, but I'm going to focus a little bit on metabolic health. So you see an increased rate of diabetes and depression, also vice versa, even when you control for lifestyle factors, even when you look at treatment-naive patients. So this is a kind of very robust finding about the comorbidity between metabolic and mental health. We started to think these features that people described symptomatically, these neural aspects of disrupted processing of bodily signals, and also this mortality gap and its relationship with cardiometabolic disease specifically, might all be roughly looking at the same problem, which is the problem of disrupted bodily signals and interpretations of those signals across mental health conditions. And I think those two features interact with each other. So experimentally, we've used exactly that same task in a group of people with diabetes and also risk of diabetes. This is the acceptance bias parameter that I showed you scaled so equivalently with anhedonia and apathy, and you see the exact same thing with diabetes and diabetes risk. So the worse your metabolic health, here captured as risk of diabetes, the lower your acceptance bias. This is independent of any psychiatric comorbidity, so controlling for psychiatric symptoms, psychiatric burden. Interestingly, this is not specific to something like metabolic health. We see a not completely overlapping, because there's another effect, but a similar effect across the menstrual cycle. So this is a within subjects effect, where when they're at particularly vulnerable points in terms of mental health across the menstrual cycle, this perimenstrual period, you also see a dip in acceptance bias. And you also do at the time of day that is incompatible with your chronotype, when people also tend to feel worse. So it seems to be this acceptance bias mechanism doesn't seem to just explain anhedonia, but actually seems to explain changes between people and within people in their vulnerability to these kinds of motivational mental health symptoms. So what we've begun thinking about on a theoretical level is how this plays out and where it might originate in the brain and in the body. And I don't want to leave you with the idea that I think there's some kind of original cause of a physical signal, or indeed a brain signal that's disrupted, that is trickling down and causing all these problems. What I actually think is that there are multiple levels of this kind of model at which disruptions can occur that then have knock-on effects on other levels. And that might originate with changes in insulin signaling or ghrelin signaling or some kind of metabolic signal. It might originate with entirely changes in the brain and changes in interpreting those signals, or even something more abstract than that, in changes in interacting with the world around you that then have repercussions for your metabolic health. So for example, changes in behavior with how you deal with appetite and also how you deal with exercise would naturally have metabolic consequences. So you can imagine many levels at which these kind of comorbidities can occur and lead to results like this. Here's a study we ran using a different type of computational modeling called reinforcement learning modeling, where we showed that people's learning rates from recent rewards, so the higher your learning rate, the worse their metabolic health. And I say worse here, these are actually all healthy participants, but the closer to diabetes, so that pink dot is someone who's a little closer to diabetes. So there's some kind of interaction or association here between metabolic health and also reward learning. There's similarly, in this exact same study, an association with depression symptoms. So this kind of reinforces our idea that although we don't know the cause yet, and in fact I think there are many causes, these associations seem robust at many different levels of this model. And this is the way that we think about it, that it essentially is a common causal factor that can come from many places and can lead to these comorbid conditions. So in the last couple minutes, I wanted to tell you sort of the now what of all of this. I started with a treatment study. I then really took a lot of steps backward and started exploring just motivation in general. And I understand that from the perspective of like translational mental health or my ultimate goals of treatment, that is definitely a step backwards. But the reason I've done it is because I think I and maybe others were in the wrong place at the time, really trying to identify particular mechanisms common across a single disorder, and I think that may have been a mistake. I think that we are more likely to identify treatments by looking at common mechanisms across disorders, maybe even across mental and physical health, and developing treatments that might address aspects of those mechanisms. And I'm quite agnostic as to the kind of treatment. So you do meet people in this field who are very devoted to a particular line of treatment. I actually think that there is unlikely to ever be one treatment that works for everyone. So really in this kind of work, I'm very interested in treatments like exercise, which seem to affect these same kind of motivational symptoms, as I am in new types of antidepressants, as I am in other forms of psychological therapy like behavioral activation therapy that affects motivation. And the way that computational psychiatry can kind of get in on this, and an approach we've used previously, is by looking at active ingredients of psychological therapy, having someone practice a bit of psychological therapy. In this case, it's a form of psychological distancing, but you can do it with other types of psychological therapy as well, while they're doing the kind of task you can model. So this was during a reinforcement learning task, and we found, first of all, that there was a change in learning rates just from practicing this psychological therapy ingredient, and also that this differed in its effect on your affect. So we had people rate happiness and other emotions throughout between whether you were on antidepressants or not and whether you were practicing this psychological therapy technique or not. So it's just the beginning, but it's starting to take a therapeutic lens on these same computational features that can enable translation across modalities of treatment, ideally also across human and animal studies. That's sort of something I haven't spoken about, but a really important benefit of computational psychiatry. So I'll end on just some of the things we're interested in right now. So I guess it's an idea of where we're going in the next few years. One is looking at these signals as a target. So that includes targeting hormonal factors, for example, with estrogen patches, but also targeting circadian factors or metabolic factors. And my PhD student, Annalise Wines, is leading the work on the menstrual cycle there, and Dr. Merhoff, who I've already mentioned, is leading the other two arms. My PhD student, Emily Bagley, and my former postdoc, Dr. Fleming, are both very interested in learning as a mechanism of interpretation of these bodily signals and how they impact your mental health in the future. And this includes learning about negative internal bodily states, which I haven't mentioned today, but I'm really interested in. So if you have any interest in that, happy to discuss afterward. And then I'm also interested in developing novel interventions at the interpretation level. So a lot of our work there involves brain stimulation, which is something I've worked on since my PhD, but I use a different type now called transcranial ultrasound stimulation, which enables us to target the insula and that target that I told you about. But I'm also interested in mindfulness-based therapy, and I'm running a big trial on that at the moment. All that's to say that this is where I see computational psychiatry going. This is why I think it has this kind of unique potential in this field in identifying mechanisms and mapping them onto treatments. And I've come up with, on suggestion, 3 little take-homes. The first is that I think there's a real benefit to focusing on mechanism and almost putting aside description for now. I think that there is a role to play in describing people's experiences and categorizing people's experiences, but I actually think that role doesn't have to be concurrent with treatment development, and perhaps actually our treatment development would go faster and be more effective if we put that to one side for a moment. And then I also think, as has been reflected throughout, that the most important goal of any of this work is treatment. And whilst there may be really fascinating questions that we can explore about etiology, they are important, at least to me, only in that they might inform treatment. And so bearing that kind of eventual goal in mind, I think, is quite important. And then finally, I would advocate that all explanations and also treatments should necessarily include physical as well as mental health. Otherwise, you're leaving off a huge array of mechanisms and a huge array of patient experiences. So I'd like to thank you all for your attention. Thank you to my lab. Thank you to my funders.